All right, today we are diving deep into hypercalcemia. Now, this is one of those conditions that can look like just another high number on a lab report, but trust me, it's actually a massive clue to some pretty major things going on in the body. Mastering this is absolutely essential, so let's get right into it.
So you might see a lab value with slightly elevated calcium and think, okay, so what? What's the big deal? But here's the thing we're going to see. That little extra can throw your entire body out of whack. We're talking about everything from your brain to your heart to your kidneys. It can be a quiet signal of a really serious underlying disease, and when it gets severe, it is a full-blown, life-threatening crisis.
So here's our game plan. We'll kick things off by defining what hypercalcemia actually is and what it looks like. Then we'll uncover the main culprits. After that, we'll walk through this step-by-step diagnostic process, cover how to treat it, and we'll finish up with some really high-yield clinical pearls to make sure all of this sticks.
Okay, section 1. Before we can even think about fixing this, we need to know what we're looking for. So let's define hypercalcemia and break down its classic signs and symptoms.
Biochemically, it's pretty simple. Hypercalcemia just means your serum calcium is too high. We look at two main values here. There's total calcium, but remember, you have to correct that number based on the patient's albumin level. And then there's ionized calcium, or free calcium, which is the form that's actually biologically active. A really important note, the exact numbers can vary a little bit from lab to lab, so you always have to check your local reference range.
Now, this is where it gets really interesting, because the clinical picture changes so dramatically as that number goes up. In the mild range, a patient might feel totally fine. It's often just a surprise finding on a routine blood test. But once you cross that line into moderate and severe, wow, the symptoms can escalate fast. A level above 14 is a true medical emergency, and that person needs to be in the hospital immediately. To remember all these different symptoms, we use a classic mnemonic that you absolutely have to know: moans, bones, stones, and groans. Moans is for the psychiatric stuff, like confusion or depression. Bones is for bone pain, because calcium is literally being pulled out of them. Stones, you guessed it, painful kidney stones. And groans for all the abdominal problems, like constipation. It's just a fantastic mental shortcut for a super complex presentation.
So we know what it is, but the really big question is why does it happen? Finding the root cause is the whole key to treating it properly. You can think of it like being an investigator trying to find what's messing up the body's calcium economy.
Okay, this is a hugely important point. In adults, about 90% of all cases of hypercalcemia come down to just two things: primary hyperparathyroidism or malignancy. That's it. If you remember nothing else about the causes, remember this. It simplifies your thinking right from the get-go.
The entire diagnostic workup really hinges on one single question. Is the parathyroid hormone, or PTH, involved? This one test splits our whole investigation into two separate paths. If your PTH is high, or even normal, which is actually abnormal when calcium is high, that's what we call inappropriately normal. It means the parathyroid gland itself is the problem. But if the PTH is low, the gland is working just fine. It's trying to shut down calcium production, which tells us the problem is coming from somewhere else entirely.
All right, now for the detective work. Let's build a step-by-step algorithm to systematically figure out what's causing the high calcium. This is exactly how you go from just a lab value to an actual diagnosis. Okay, so you get a lab result back. It shows high calcium. Before you go ordering a million other tests, what is the single most important, most decisive first step you should take?
The answer is so simple, but so powerful. Check a parathyroid hormone level. This is the main branch point. This is the test that's going to guide your entire investigation and tell you which of those two major pathways you need to go down. Let's follow that first path. If the PTH is high, we know the parathyroid is the issue. So the next step is a 24-hour urine test to calculate something called the calcium/creatinine clearance ratio. This basically tells us if the kidneys are wasting calcium or holding on to it. A high ratio points straight towards primary hyperparathyroidism, but a very low ratio? That suggests a rare genetic condition called FHH, where the body just can't get rid of calcium properly. Okay, now for the second pathway. If that PTH is low, your first thought should immediately be malignancy. You're going to check for something called PTH-related peptide, or PTHrP. It's a protein made by some tumors that acts just like PTH. If that's normal, then you check the vitamin D metabolites. And if those are also normal, well, it's time to work up for multiple myeloma using an SPEP and UPEP to look for abnormal proteins. It's a nice, clean, logical progression, moving from the most common cause down to the less common ones.
So once you have a diagnosis, or even while you're looking for one in an emergency, it is time to act. Let's cover how to manage hypercalcemia, from the acute crisis all the way to long-term control.
In a crisis, you need a protocol. Step 1, always, is aggressive IV fluids. Dehydration makes everything so much worse. Step 2 is to stop the bones from releasing any more calcium. For that, we use fast-acting calcitonin and then the more potent but slower-acting bisphosphonates. Step 3 is to force the kidneys to get rid of calcium with loop diuretics. But, and I cannot stress this enough, you only do this after the patient is fully rehydrated. Giving diuretics to a dehydrated patient is dangerous. And for the most severe cases, hemodialysis is our final safety net. This table really lays out the two different scenarios perfectly. For severe crisis, on the left, everything is urgent and aggressive, IV fluids, powerful IV drugs. But for chronic, mild hypercalcemia on the right, the approach is much more measured. We're talking about oral hydration, stopping any medications that might be causing it, and focusing on the underlying cause as an outpatient. Let's just take a closer look at the two main drug classes we use. Both of them work by inhibiting osteoclasts. Those are the cells that break down bone and release calcium. Bisphosphonates are the traditional workhorses for this job. Denosumab is a monoclonal antibody that targets a molecule called RANKL to block osteoclast activation. It has a key advantage, though. It's the preferred choice for patients who have severe kidney problems, which is a really common scenario here.
Okay, we have covered a lot, so let's lock in all this knowledge with a few essential, must-remember clinical pearls.
First off, remember the 90% rule. When you see hypercalcemia in an adult, your mind should immediately jump to primary hyperparathyroidism or malignancy. Start right there.
Second, that diagnostic fork in the road. What's your first, most important test? It's always a PTH level. It's going to tell you whether the problem is in the parathyroid gland or somewhere else in the body.
And third, remember this for any patient who's feeling sick from this. The first, best, and most critical treatment is IV fluids. Hydration, hydration, hydration. It is the absolute cornerstone of stabilizing your patient. So let's end with this. Remember that an elevated calcium level isn't just a number you need to correct. It's a profound clue. It's a signal that the body is sending you, telling you that something fundamental in its complex system has gone wrong. That lab value is just the beginning. The real question is, what story is the calcium trying to tell you about your patient's body?